Hello and welcome to the University of Pittsburgh's Primary Spine Practitioner Certification Program. My name is Michael Timko and I'm going to be your host for this presentation on the thoracic outlet syndrome. The objectives of this presentation are as follows. We're going to define what the thoracic outlet syndrome is from a clinical perspective and provide an overview of these clinical of the clinical manifestations of this condition. We'll understand the anatomical considerations associated with thoracic outlet syndrome. We'll recognize the three different causes of thoracic outlet syndrome, and we'll understand the strengths and weaknesses of the clinical examination procedures for the thoracic outlet syndrome. Thoracic outlet syndrome is a complex array of clinical findings. Oftentimes this is thought to be a compression or a tensioning event of the neurovascular bundle as it courses through the scalene triangle and into the upper extremity. There are a variety of other factors that can be involved, and many of these are listed for us on the current slide. As you can see, as listed on the slide, there's a variety of other names or syndromes, sort of subtypes or subclassifications of what the thoracic outlet syndrome actually is. There are various entrapment sites or areas where the neurovascular bundle, as it courses from the central structures out into the periphery, can potentially become entrapped or compressed or potentially tensioned in an adverse way. The first of these is the cervico-axillary canal, sometimes referred to as a thoracic outlet itself. Essentially, this is a tunnel through which the neurovascular structures will pass. It is defined by bony aspects, including 5 ribs, the clavicle, and the scapula. And there are actual muscular components, including the scalenes, the pectoralis minor, as well as the subclavius muscles. The first rib will actually divide this canal into both an upper and lower section. The cervicobrachial canal, or the thoracic outlet, if you will, can also then be looked at in terms of the structures that will come coursing through here. So when we talk about the neurovascular bundle itself, we're talking about the brachial plexus and its branches, as well as the subclavian artery, vein, and their various branches as well. In terms of the anatomical sites of compression, in the upper section of this thoracic outlet, there is the interscalene triangle, and there's the costoclavicular space. The anterior and middle scalenes, as well as the first rib, make up that interscalene triangle, whereas the clavicle, first rib, and the superior aspect of the scapula will make up the costoclavicular space. In the lower section of the thoracic outlet, the thoracocoricopectoral space, and this is primarily defined, if you will, by the pectoralis minor, the coracoid process, and ribs 2 through 4. Additional sources of compression of the neurovascular bundle can include the subclavius muscle. Note, the subclavius muscle does not actually attach to the scapula, but basically will run its course on and along the underside of the clavicle itself, attaching on the costocartilage of the first rib, and again with its terminal attachment on the clavicle itself. In terms of the trunks of the brachial plexus and their piercing through the anterior scalene, and realize that this can be a somewhat variable course depending on the individual. So sometimes the aspects of the brachial plexus will run behind, or sometimes some of the trunks may actually come piercing through the scalene musculature as depicted on the slide. Additional sources of compression can be what are referred to as the cervical ribs. The cervical ribs are actually projections of the transverse processes of the cervical vertebrae. These are often found can be found unilaterally, but they can be found bilaterally as well. These are commonly associated with compression on the subclavian artery, resulting in more of an arterial type of TOS as opposed to a neurogenic form of TOS. These slides here are depicting a couple of different types of these cervical ribs. A type rib being more of a longer rib projecting from the seventh cervical vertebrae with a short fibrous attachment onto the first rib. A second type of cervical rib, again coming and projecting off of the seventh cervical vertebrae, this time with a longer fibrous attachment onto the first rib itself. Some additional sources of compression can include enlargement due to soft tissue compression. So this can be sometimes the development of scar tissue that might be associated with the anterior scalene. This can be seen at times status post whiplash mechanisms or motor vehicle accidents. There are also times fibrous bands that can develop with time or develop congenitally that will also constrict the amount of space that is available for the neurovascular bundle to course through. In terms of the categories of thoracic outlet syndrome, they can basically be broken down into two types, vascular, and the vascular types now can be subdivided into either arterial or venous. And again, these are the more rare types of thoracic outlet syndrome. The more common type of thoracic outlet syndrome is the neurogenic type, believed to be about 95% of these syndromes. Again, these can actually be subclassified into true neurogenic that is able to be confirmed and validated through diagnostic testing, or what is referred to as disputed neurogenic TOS, where there is the inability to confirm involvement through standard diagnostic testing. In terms of differential diagnosis, and many times thoracic outlet syndrome is thought to be a diagnosis by exclusion, given that the number of conditions that are listed on this particular slide have been ruled out through clinical testing or diagnostic testing. And it's entirely possible that other features, such as carpal tunnel syndrome, can sometimes make the diagnosis of TOS even a little bit more complicated. So again, as we mentioned earlier in the presentation, thoracic outlet syndrome is sometimes a fairly complex array of clinical signs and symptoms, and diagnosis isn't always straightforward and easy to make. In terms of some of the symptoms that are associated with thoracic outlet syndrome, and again, going back to the difficulty in arriving at this diagnostic conclusion, other peripheral neuropathies, such as carpal tunnel syndrome or maybe even a cubital tunnel syndrome, can occur in conjunction with or maybe mimic features, signs, and symptoms that we would associate with a true thoracic outlet syndrome. So again, careful diagnostic consideration and being able to systematically work our way through the upper quarter to arrive at these diagnostic conclusions, again, that is the challenge that we face as clinicians. When you look at the common features of thoracic outlet syndrome and what patients will be complaining of, in most cases, there's going to be some form of upper extremity paresthesias. They may report some stiffness or tightness or maybe even pain in the trapezius area. Some may also experience some lateral neck pain or discomfort as well. The majority of patients will also experience some type of shoulder and arm symptoms. They may also present with some supraclavicular pain, occipital headache, chest pain, and hand paresthesias have also been reported in patients with thoracic outlet syndromes. In terms of the types of thoracic outlet syndromes, let's focus now on the arterial compression, and the common signs and symptoms that are associated with this type of thoracic outlet syndrome are listed here on the slide. The best way to think about an arterial form of thoracic outlet syndrome is to think about this as a supply side deficit. In other words, fresh blood, fresh oxygen being able to flow through the thoracic outlet into the upper extremity. This is being compromised, this is being restricted, and therefore an ischemic reaction is going to be experienced by these tissues that are downstream from the site or the area of the entrapment or the compression. Allen's vascular occlusion test is sometimes helpful in this particular instance, where when we occlude the arteries and we look for the refill or we look for the return of flow, what we'll see is a delayed response, or we'll see a delayed whitening, or I should say a persistent whitening maybe of the hands and fingers, even once the artery and the flow has been restored. So again, the specificity of Allen's test here is fairly high. Its sensitivity is a little bit lower, but again, it is thought to be associated with an arterial deficit in that upper extremity. In terms of a venous compression, or the other type of vascular thoracic outlet syndrome, this is where we can now think about the return phase on the vascular equation. This is where blood returning via the venous system now is being impaired. And what we're going to see here now is a backup in the system. So oftentimes the hand, forearm, upper extremity itself may become a little bit more edematous. We may start to see signs associated with a cyanotic type of presentation. And again, this will be a clear differentiation from what we see from the arterial side of things. The concern that we have with these venous type of situations is the development of a possible DVT, and this may actually be experienced by some of the athletic populations that are out there, namely overhead swimmers and throwing athletes may potentially become susceptible to this type of impairment, and this needs to be addressed fairly immediately, as there could be some more significant consequences if this does not get identified and appropriately addressed. From a medical diagnostic perspective with regards to these vascular forms of TOS, there's a variety of things that can be done that include everything from plain radiographs to a variety of vascular scans that can demonstrate or depict the type of flow deficit that might be present in the individual that is experiencing these types of complaints. The most common form of thoracic outlet syndrome is referred to as the neurogenic type of thoracic outlet. And this is oftentimes associated with trauma, potentially motor vehicle accidents, or with a lot of repetitive movements, again, overhead activities, a lot of repetitive movements and activities involving the upper extremities, especially on the dominant side. Patients will complain of pain, paresthesias, potentially numbness and or weakness. Again, oftentimes what we see is the lower portion of the brachial plexus becoming involved in these cases, but it can potentially involve the upper portion of the brachial plexus as well. The diagnosis of true and disputed neurogenic TOS, again, the difference here being confirmation via clinical and or diagnostic test findings. So again, for true neurogenic TOS, This is going to be based on the symptoms that were noted in the previous slide and at least 2 positive provocation tests clinically, and the EAST test, or the elevated arm stress test, is almost always positive in these instances. To that end, once the clinical suspicion is raised, it can be confirmed with further neurophysiological testing, namely EMGs or NCVs. The disputed symptomatic neurogenic TOS, which is probably the most common form of thoracic outlet syndrome, will have the clinical manifestations that were mentioned previously, but in these cases, the neurophysiological testing, negative vascular test, and negative imaging tests, negative EMG NCVs, that becomes the difference between these 2 subcategories of neurogenic TOS. The other way that these patients with thoracic outlet syndrome are sometimes characterized or looked at is the patient an actual compressor, or are they potentially a releaser? And what this is basically referring to is, again, the tension or the compression that is placed onto the neurovascular bundle and the manner by which this can either be exacerbated or relieved. So when we think about the compressors or the compressing phenomena, these are typically individuals that will experience symptoms during the day, especially with overhead activities. They will end up increasing tension or compression on the brachial plexus during these activities. These patients will oftentimes not experience any symptoms at night unless they happen to sleep with their arm in an overhead position. Oftentimes these individuals are involved in occupations or activities which will put them into these compromised positions on a fairly regular basis. The EAST test or the RUSE test or the elevated arm stress test is oftentimes positive with these patients, and what they're primarily experiencing is a compression that is somewhat intermittent in nature, and as soon as the compression is removed and flow of blood and tension on or compression on the neurovascular bundle is released, then symptoms are oftentimes relieved. The release phenomena is sometimes part of what the patient will experience or report in various clinical manifestations. So when the brachial plexus is under constant tension due to poor posture, the weight of the arm essentially at the side during the day, there is a nerve stretch or tension that will result potentially in some venous pooling around the nerves, inhibiting blood flow to these nerves. In bed, the tension can be released, blood flow returns, axonal flow returns, and the patient may experience some paresthesia. Signals of a return include sensation. Actually, when we see this type of return of sensation, this is usually a good prognosis for recovery, and this is essentially what can be witnessed clinically by performing the Syriac's release test. In the releaser category of patients, these are typically patients that may experience their symptoms at night. They may suddenly be awakened by paresthesias, and this is, again, there's been a release of tension and or compression on the neurovascular bundle, and it's the change in flow dynamic now that is creating the sensation. Many of us have experienced this phenomena if we've slept on our arm in a funny way at night sometimes. We wake up in the morning and we sort of have a dead arm, but there's sort of that immediate experience of a shower of pins and needles running down our arm, and it usually lasts anywhere from 30 seconds to a minute or more until that flow has been completely returned. So again, patients will have some concerns with this. It is somewhat alarming when they experience it maybe for the first time or if it's starting to occur on a regular basis, but in many respects this may also be a good sign that by improving posture, improving sleep position, doing some other things in terms of alignment, we may be able to manage these symptoms quite effectively. These next several slides now are going to look at some of the various tests that are used for clinically determining the presence of thoracic outlet syndrome. What we're going to find with the vast majority of these tests, while we may be able to alter or change the patient's presentation, we will be challenged, though, to actually bring the whole clinical picture together, as there's a high rate of false positive and false negative information that we may be getting from some of these tests. In addition, a lot of these tests try to exploit the vascular factors that are present in some cases of TOS, but as we just discussed, the most common form of TOS is the neurogenic version. And so again, some of these tests may not necessarily be as helpful or as useful in helping us to arrive at our clinical diagnosis. So this first slide here is our Cyriax release test. And again, this sort of is an attempt to create the release phenomena. So the tension is present in the system, and then the idea is the patient releases that tension and there's an alteration or change in the symptomatic experience of the patient. From the subjective examination, what we may find or what our patients may report are some of the following items that are listed on this slide. In many respects, what we'll see from the patient is a complaint of arm symptoms, oftentimes in the C8, T1, or ulnar nerve type distribution. Oftentimes we'll be able to observe some poor postural alignments from our patients, as many of these individuals may present with elevated shoulders, rounded shoulders, forward head type posturing. We may be able to witness some skin changes, some color changes, potentially some swelling, but there may also be the absence of some of these signs. In terms of a cervical movement pattern, oftentimes what may create the increase of symptom into the affected arm would be the cervical movements away from that arm. So if I'm experiencing some right arm symptoms, it would be movements of the head to the left or tipping the head to the left or sustaining those left-sided positions of the head that then bring on the experience of symptom in the involved right upper extremity. Again, as we tension that brachial plexus by turning away from the affected side, this is believed to be the mechanism by which we're able to change or alter the symptoms. As I mentioned before, there are a variety of tests that are out there, including the RUSE or the elevated arm stress test, Adson's test, the costoclavicular test, Wright's test, the upper limb tension test. And as the slide basically shows here, all of these tests have potential problems or issues in terms of their clinical utility, and we need to make sure that we understand this and that we're sort of aware of these considerations when we're looking or utilizing these tests for our patients that are presenting with some of these signs and symptoms. So again, the pictures here outline the test. The RUSE test, or the elevated arm stress test, is commonly used as a screening test for thoracic outlet. And what we're primarily looking for here is the reproduction of the patient's primary symptomatic complaint. Again, oftentimes in that C8 to T1 type distribution when the arms are in that elevated position. It's very important that the patient be in an upright position. It'd be very important that the shoulders are elevated effectively to at least 90 degrees, maybe a little higher than that, and that the arms are also slightly extended so that we bring the chest forward, we bring the shoulder back a bit so that we are clearly putting the stress of the test and the position into the thoracic outlet area. Adson's test is basically a vascular test where we're monitoring the radial pulse. And in this particular instance, the arm is going to be slightly extended while the patient rotates the head towards the side, creating some compression into the thoracic outlet regions. And we're looking for a diminution of the radial pulse while the patient is in that position. And again, what we probably want to be considering when we do these tests is the comparison of the symptomatic side or the involved upper extremity to the response on the uninvolved side. Of course, this becomes a little bit more complicated to do if the patient should happen to be experiencing symptoms in both arms. The costoclavicular test or military brace test, again, places the stress in the thoracic outlet region more into that costoclavicular area. So in this particular instance, again, we're monitoring the radial pulse while the arm is being held and maintained in an extended position. The Wright's test, sometimes known as the hyperabduction sign as well. This is where we're going to take the arm up into an elevated position and again monitor that radial pulse for any changes in potential flow through that particular artery. Again, what makes this test difficult is that even in the normal situation, elevating the arm may result in a diminution of the pulse, and this may not necessarily be indicative of thoracic outlet, but rather just be a little bit of a normal variant that doesn't necessarily contribute to the patient's symptoms. The upper limb tension tests have also been thought to potentially have some value here, especially in terms of the neurogenic subtype of thoracic outlet syndrome. So again, the comparison of involved side to uninvolved side through the various maneuvers and positions that are available here may also be revealing in terms of the mobility, again, of this neurovascular bundle through the various places of entrapment in the upper extremity. In terms of treatments and treatment outcomes for thoracic outlet syndrome, this is a challenging clinical proposition. This is oftentimes a difficult syndrome to manage because it is influenced by a variety of factors, some of which we can influence readily with clinical interventions, some that are not as easy to influence via our clinical interventions. So again, there's not necessarily a strong consensus out there in terms of what optimum treatments look like. There really is no standard of rehabilitation when it comes to management for thoracic outlet syndromes. Research in this area is somewhat limited, and a lot of what has been looked at are some of the vascular situations where maybe a surgical intervention was necessary, whether that be the removal of cervical ribs or addressing the DVT, but there's not a lot of information or a good amount of studies out there that are basically dealing with the neurogenic and especially the disputed neurogenic type of thoracic outlet. So oftentimes treatment approaches are somewhat intuitive based on our understanding of anatomy and posture and biomechanics. And oftentimes these approaches that are taken need to be fairly comprehensive and then individualized to the patient themselves. I'd like to acknowledge a couple of resources here with regards to this presentation, namely my colleagues at West Virginia University, Dr. Scott Davis and Mr. John Petronis, who helped to put this presentation together. Also, in addition, the protocol that is listed here that was put together by Dr. Ronald Lefebvre. This was a article that was utilized in the bringing this information together to share with you. So I'd like to be able to acknowledge those individuals in this presentation. So to conclude this discussion now on our thoracic outlet syndrome, I'd like to go back and just touch base on our objectives once again. So we discussed and defined what the thoracic outlet syndrome is and the various subtypes and manifestations of this clinical syndrome. And again, those subtypes include both vascular, which can be either arterial or venous, and then neurogenic, which can then be subcategorized into either true neurogenic TOS, which can be confirmed by diagnostic testing, or disputed neurogenic TOS, which will have clinically relevant signs, but the diagnostic testing results oftentimes come back negative. The other thing that we want to be able to realize and recognize is that the clinical tests and measures here, while they have some utility for us in getting us to understand the patient's presentation, the tests are not definitive, and oftentimes they are mired with high false positive and false negative rates, and we need to be able to keep that in mind when it comes to making the thoracic outlet diagnosis. So again, I'd like to thank you all for your participation in the University of Pittsburgh's Primary Spine Practitioner Certification Program. Again, my name is Michael Timko, and I thank you for allowing me the opportunity to share this presentation with you.